saying that lung disease is a huge public health challenge. It really has not been addressed properly, and we need to work together to try and develop a national public health strategy to try and improve lung health outcomes and increase awareness of lung disease. So, thank you.
Thank you very much, Dr. McKeown, for your very interesting and sobering presentation, and thank you for your words. I want to welcome now from the Asthma Society of Ireland, Ms. Sharon Cosgrove, the Chief Executive Officer, and Dr. Basil Eliezer, Medical Chair. And I'm not sure who's making the presentation. I think it's Sharon, is it?
Yeah, I'm going to start.
Very good.
Excuse me, I'm going to start off.
You have 5 minutes.
Okay, thank you, Chair. Asthma is the biggest chronic disease that affects the largest number of the population in the country. We estimate that there's 470,000 people with asthma, and the Asthma Society of Ireland has been operating for about 40 years, representing people with asthma, providing information and education and services. And as Dr. McKeown said, one of the biggest challenges we have is education in terms of the patients, but also trying to advocate on their behalf to have the best possible treatment and guideline-based care in public policy and in the health services. We have an advice line, and we deal with patients, 2,000 patients every year. We have clinics, so we do what we can with the limited resources that we have available to us. We've no statutory funding at all for our core services for patients, so I just wanted to raise that at the beginning. But in terms of the numbers, as I said, 470,000 people in the country have asthma. It's the 4th highest in the world in terms of asthma. And we're the largest, or people with asthma are the largest chronic disease group in the country. 1 in 10 people have asthma, and from a children's point of view, 1 in 5 children have asthma in this country. So it's an enormous problem from a children's and a paediatric health point of view. One of the things to say is that asthma isn't curable. It's a condition of the lungs, which can be controlled and managed with correct medication and with education of patients. One of the tragic things is that 1 person per week dies of asthma in this country, and a number of those are young people. And we have contact from schools, from parents, from children who've lost friends to asthma, children who've been on sports day or on the field playing a game of football where they've caught their breath, they can't catch their breath properly, they have an asthma attack, and regrettably they've died. So these are preventable deaths, particularly in young people. So we'd obviously be very keen to advocate for a very comprehensive programme to be implemented to deal with this sort of thing. It's one of the conditions, one of the chronic conditions that can be very effectively managed in the main in primary care. 85% of the people with asthma can be managed in primary care. The remainder need more secondary care treatment, dealing with consultants and hospitals, and a number of those in both as a sort of shared service. We have 20,000 people attend A&E every year due to an asthma attack or an asthma exacerbation. The average length of stay is 3 days. 500 people require emergency nebulization. 50,000 people require emergency nebulization. And in terms of cost, something that isn't factored in is that adults with asthma miss on average 12 days per year from work, and children on average 12 days from school. So when you think about children and the impact that has on their education, on their participation in sports and regular everyday activities, it's quite enormous. Children talk about the fact that they play sports, they run, they can't catch their breath, they can't participate in the same way as other children can. So children with asthma and people with asthma are affected day to day with very basic things like walking up the stairs or running for a bus. The things we'd like to advocate for and ask for, really from a public policy point of view, is that the National Asthma Programme, which was adopted by the government in 2011, is implemented. That there's a public drive or a politician sort of government drive to implement this programme. We need some impetus behind it to get it through, to get the resources at sort of primary and secondary care level to address these problems. The other thing that we wanted to raise was in relation to Xolair. It's a medication, a drug, which Dr. El-Nazir can go into in more details, that is for severe asthma patients. And there's inequity of access to it. It isn't covered by any of the reimbursement schemes, and it's identified in the GINA guidelines, the international guidelines for asthma, as the appropriate treatment for the most severe allergic asthma patients. So they're the two things we want to push for today, are the implementation of the programme and some type of action to address the fact that there's inequity of treatment. Spoke to a consultant yesterday who has 40 patients in CUH in Cork who can't get his patients access to this drug and who badly need it. Thank you.
Okay, thank you very much indeed, and we'll discuss that maybe more on the questions and answers with members in a minute. But thank you for your excellent presentation. I want to welcome from the Cystic Fibrosis Association of Ireland, Mr. Philip Watt, Chief Executive Officer, Ms. Caroline Heffernan. I think Mr. Watt is going to make the presentation.
Thanks very much, Kierlock, and thank you to public representatives after a very long night. I really appreciate you being here, and to Professor Crown who facilitated the meeting today. I'd like to also welcome Caroline Heffernan, who's a patient advocate and a person with cystic fibrosis, who's with me here today. Cystic fibrosis, as you know, is an inherited chronic disease which primarily affects the lungs and digestive system of about 1,200 children and adults in Ireland. A defective gene causes an unusually thick and sticky mucus to build up that clogs the lungs and leads to life-threatening lung infections and obstructs the pancreas and stops natural enzymes from helping the body break down and absorb food. Our association is the only national patient CF group in Ireland. We were formed in 1963, and this year is our 50th birthday, which is a fantastic achievement, along with the Irish Cancer Society. In the 1950s, very few children who had CF lived to attend primary school. And today, thanks to advances in research, medical treatments, and fantastic clinicians we have here, there is further enhanced and extended life for children and adults with CF. However, the disease remains very challenging. The median age of death is still around 25 years of age. But thanks to the good care standards in our hospitals, people with CF are expected to live into their 30s and beyond. And increasingly, some of our members are attending third-level colleges, accessing employment and living in more independent lives with the support of their family. But this also puts major demands on adult CF services in particular, and there's a deficit particularly of adult CF services, also of children's services, but adult services in particular. As you know, Ireland has some of the most severe manifestations of cystic fibrosis in the world, and also has the highest incidence of cystic fibrosis in the world, with 3 times the rate of the United States and the European Union. So there's just a number of key points that we'd like to draw to your attention today. First of all, is to acknowledge some of the recent improvements in CF care, but we are still catching up with accepted standards in the US and other parts of Europe. The recent approval of the groundbreaking drug Kalydeco, the introduction of newborn screening in 2011 for CF, and the long-awaited unit in St Vincent's Hospital are just some examples of very positive developments. However, huge challenges remain. For example, isolation facilities are still needed around the country, and there's an urgent need for 13 adult inpatient isolation rooms in Beaumont Hospital. There's only 4 there at the minute, and with some 130 adult patients. It's estimated that the costs of this project are relatively modest, 2.5 million for capital costs, but indications are to us as an association is we have to collect the money for that project through our fundraising, which is not entirely fair, I think, on the patients and their parents who have many other demands in terms of managing this disease. There are also major infrastructure deficits in many other centres around the country, which I've listed in our presentation. There's need for an increased rate in double lung transplantation, and we're delighted to hear that this week there's been 3 such transplantations undertaken in the Mater Hospital. But we really need to double the present rate of transplants. Transplants are really needed at the end of people's lives, and it can make a major difference in terms of extension of people's lives and the quality of their life. So we would urge that there would be more transplants done in Ireland, and we acknowledge the fantastic quality of the transplantation that is undertaken. We'd also draw attention to the committee to the non-replacement or significant delays in the replacement of dietitians, specialised nurses and physiotherapists, which are affecting all the groups who are represented today. Those on maternity and sick leave are not being replaced, and that is causing real hardship for many of our patients. Annual assessments in some of our hospitals, which are vital for people's health, are being cancelled or deferred because of staff embargoes. We also object to the recent prescription charges for medical charge holders. That increase of 50 cents per item is up to a monthly limit of $19.50 per family, is causing significant hardships on our patients, but particularly because of the amount of medications that our patients need to take every month. We also need to preserve research funding and into new and innovative treatments, as the recent drug Kalydeco shows. And we would urge that the funding for schemes such as that operated by the HRB and the Medical Research Charities Group is maintained. And finally, the point that Dr. McCone made at the start of the presentation, the need for lung health in general to become a much more important public health priority than it is at the minute. That is very consistent from all the messages here today. It needs to be given a much greater priority. Also, practical initiatives such as greater emphasis on the flu jabs and also the vaccination for pneumonia, which is very important for vulnerable groups, but doesn't perhaps get very much publicity. The need for that are absolutely vital as well. And we'd call on partnership approach with NGOs working with clinicians through the Lung Health Alliance and the state as an effective way of going forward. Thank you very much, Ciara.
Thank you very much, Mr. Watt, for your presentation and for your words. And I want to welcome now from the Alpha One Foundation, Ms. Kitty O'Connor, Chief Executive Officer, and Professor Jerry McIlvany. You're very welcome. So
thank you.
Thank
you, Deputy and Senators, especially, as I said, in the night and the day that was in it. I'd like to welcome Professor Jerry McIlvany, Respiratory Consultant in Beaumont Hospital and also Chairman of the Alpha One Foundation. So briefly, I'm just going to give you an overview about Alpha One, the Alpha One Foundation, and our involvement with the Irish Lung Health Alliance and how important it is to us. And you might say to me, what is Alpha One? We haven't heard of this before. You might commonly have heard of this as hereditary emphysema, and that is Alpha One antitrypsin deficiency. But this is also a genetic condition. It can cause liver disease. The Alpha One Foundation was set up as a lung charity. It's based in Beaumont Hospital, and that's the National Referral Centre for Alpha One. And I know you've been given a lot of statistics this morning, but here's another one. 1 in 25 people in Ireland are carriers for this condition. And this makes it the second most common genetic lung condition in Ireland, next to cystic fibrosis. Alpha One is the fourth most common cause for lung transplantation in the world. And just to put this into the Irish context, the first single lung transplant and the first double lung transplant in Ireland was an Alpha One patient. Our research that we've done recently has showed that on this island of Ireland, over 3,000 individuals suffer with a severe form. But there's also 200,000 that also have a deficiency, and they're also at risk of lung disease if they smoke. A national targeted detection programme was established to test people with chronic obstructive pulmonary disease, or you might know this as COPD, poorly controlled asthmatics, unexplained liver disease, and first-degree relatives of Alpha One. Early detection of Alpha One is vital, and it gives us a real example of how personalised medicine in this age can come and yield improvements in quality of life, life expectancy, and smoking cessation. And to date in our programme, we've screened over 10,000 individuals. 300 of those have had the severe deficiency, and 2,000 have had a milder form. 26 different hospitals participate in this programme, so we feel it's vital for the maintenance of this target detection programme. And just how we became involved with the Irish Lung Health Alliance, we decided that we wanted to highlight lung disease in Ireland. So we joined up with other groups, patient support groups and health professionals. There's 12 of us in total, and this gives us a unique partnership with all these key stakeholders in lung health. Its key messages are the same as ours: early diagnosis, early intervention, and increased awareness of lung health. We've found we've benefited from the involvement and membership of this group. And last year, you might have read something about the Love Your Lungs campaign, where we had Dr. Ronnie Delaney supporting our cause. And this was aimed to highlight that lung disease can affect all people, all socio-economic groups, non-smokers as well as smokers. We encourage people who had symptoms like cough, wheeze, shortness of breath to get a simple free lung test. In this way, the same way as you can get a blood pressure measurement done, you can get a simple lung test done to see if you have any lung disease. This campaign highlighted the fact, as Dr. McKeown has said, that lung disease is highly prevalent and underdiagnosed in Ireland. The Irish Lung Health Alliance wants to involve all stakeholders in lung health and give a voice to hundreds of thousands of patients suffering with lung disease. Our main aim here this morning is to highlight the fact that we would like to be the contact for government in efforts to raise awareness for lung health and its importance in formulating future lung health policies. And thank you for your time.
Thank you very much indeed, and for your interesting statistics which we didn't aware, which I wasn't aware. I wanted to read your presentation for today, but thank you. And I want to know, welcome from the Irish Sleep Apnea Trust, Mr. Dan Smith and Mr. Arthur O'Hara. You're both very welcome, and Ms. Smith, you're going to make the presentation.
Thank you very much, Chairman. Just initially, the Irish Sleep Apnea Trust was formed in the year 2000. We're completely non-profit volunteers, and we receive no state funding. First of all, I'd like to go through what is sleep apnea. Sleep apnea, we spell it the old Greek way, A-P-N-O-E-A, and the Americans spell it N-E-A. It's a respiratory sleep disorder where the sufferer frequently stops breathing while they sleep. Breathing cessations last for at least 10 seconds and may be accompanied by a drop in blood oxygen saturation levels or even a cardiac event. The name sleep apnea is derived from apnea, a Greek word meaning without breath. It's a very serious medical condition which in its severest form can cause premature death. There are three main types of sleep apnea. We have obstructive sleep apnea, which is very much the most common. It's caused by an obstruction or a collapse of the airway. We have central sleep apnea, which is a neurological condition where basically the brain forgets to tell the body to breathe. It's very serious but very, very rare. And then we have a mix of the two. Severity of the condition is measured by a thing called the apnea-hypopnea index, an AHI, which in effect is a cessation of breathing. So anything within a range of 5 to 15 times per hour is mild, 16 to 30 is moderate, and above 30 is severe. That's stopping breathing 30 times during your sleep every hour. There's very serious health risks, obviously. We have excessive daytime sleepiness, which leads to poor work performance and a high risk of road traffic accidents. We have an increased risk of cardiac disease and stroke, increased risk of diabetes, and increased risk of glaucoma. The symptoms include severe snoring, hypertension, diabetes, severe mood swings, excessive daytime sleepiness, impaired cognitive function, impaired short-term memory, and a thing called nocturia, which involves frequent bathroom visits during the night. Treatment is very simple. It's by way of a device called continuous positive airway pressure, called CPAP, which basically splints the airway open by an airflow which is set at a particular pressure. There's also a device called an oral appliance, which is made by a specially qualified dentist, which draws forward the lower jaw, and that has proved effective in dealing with mild and possibly moderate apnea. To go through the numbers, population studies carried out in the 1990s indicate that 4% of the adult male population and 2% of the adult female population suffer from sleep apnea, and 0.5% of children suffer from sleep apnea. Now, more recent studies indicate that up to 10% of the adult population and 3% of children suffer from sleep apnea. In the case of children, there's a very close link to children with Down syndrome. 45% of them are likely to develop sleep apnea. So basically, the figures are looking in the 1990s studies of up to 112,000 sufferers in Ireland, and it could be as high as 360,000. So if we take a best case scenario, there's a significant number of people in Ireland with the condition. The large increase in the number of children suffering from this condition is a major concern. Moving on, I'd like to take this under two headings. One is sleep apnea in adults and the other under the paediatric area. The current position in Ireland is that a number of health service executive managed and voluntary hospitals offer a type of an ad hoc service. There's no structure to it. There's no national structure or framework for dealing with the condition in the public health system. The type of service offered varies from hospital to hospital, with only one HSE hospital offering dedicated sleep disordered beds. In many cases, diagnostic testing is suspended when an acute hospital finds itself busy, usually through a busy night in A&E. Typical of this is a current problem in Dublin, where possibly the largest unit in the country at St Vincent's University Hospital, has its staff reduced and is facing the prospect of a vastly reduced service from June of this year. They're looking at halving the service, basically. ISAT have met with the CEO of the hospital, who has no money, and the HSE have not responded to correspondence. Beaumont Hospital, and there the sleep disorders unit is located in St Joseph's Hospital, Raheny. And I might add that the public unit there was funded by private sources. It's been closed since mid-December last, as there's a perceived safety issue. I don't know what it is. Since sleep studies have been suspended there has been a situation where up to 100 patients are left in limbo. There are similar problems throughout the country. It should be pointed out there are no sleep medicine consultants employed by the HSE. In Ireland, the diagnostic work is carried out by respiratory consultants who give up a percentage of their time to deal with this condition. There are many clinical studies available which prove that sleep apnea patients who are being successfully treated are less likely to develop cardiac conditions, are up to 33% less likely to get a stroke, and usually have fewer visits to their GP. ISAT have pleaded with 2 health ministers to introduce a national strategy to deal with this problem, to no avail. Only recently, and this is this year, the Road Safety Authority has issued new guidelines to general practitioners on fitness to drive, and this is for Group 1 drivers. On page 56 of this document is a section covering sleep apnea. It states that drivers who suffer from symptoms that are sleepy must not drive and must report this to their driving licence authority. GPs are not qualified to diagnose this condition, and with an ad hoc sleep disorder service whose capacity is being reduced, we fail to see how these regulations can be enforced, particularly if a suspected sufferer of sleep apnea may have to wait up to 12 months to get officially diagnosed and then has to wait further to get treated. It is an absolute must that a national strategy be introduced. I want to go through children, sleep apnea in children.
Briefly, you can, please.
Pardon?
Your 5 minutes have elapsed.
Oh, has it?
Yeah, but go on, you go ahead.
Could I just
You can, of
finish
course,
off
yes.
here?
Yes,
okay.
go ahead. Yeah.
Sorry. The situation with children with sleep apnea is even worse. Sleep apnea in children is a very different condition to that in adults. It is frequently associated with conditions like ADHD, and approximately 45% of children with Down syndrome are likely to develop the condition. There is no structure at all, with a number of hospitals offering ad hoc services. There are no sleep consultants employed by the HSE. As with adults, a number of respiratory physicians coupled with respiratory scientists offer very limited services. The following hospitals offer some degree of service. We have Our Lady's Hospital for Sick Children in Crumlin, Temple Street Children's Hospital, Adelaide and Meath and Tala, Cork University Hospital, Galway University Hospital and Midwestern Regional Hospital. We believe that paediatric units in Mullingar, Cavan and Drogheda have shown an interest. In many cases, these centres cannot offer the full overnight sleep test called a polysomnogram and rely on the less reliable oximetry test. To give an idea of the scale of the problem nationally, in 2007 there were 433 tests carried out, that's polysomnograms and oximetry, in paediatric units. In 2011 there were 1,793 tests carried out, that's an increase of 414%. The number of children on non-invasive ventilation increased by 627% over the same period. Waiting times for oximetry testing are in excess of 8 months, and waiting times for polysomnograms are over 12 months. It's no way to treat our children. A national strategy is required, whether it be done jointly or severally. It is a must. And I won't go any further.
No, go ahead, you go and finish your presentation.
Okay.
Yeah.
Just to summarise, the diagnosis and management of sleep apnea is something that cries out for an introduction of national strategy, both for adults and children. From an adult perspective, the introduction of fitness to drive guidelines for Group 1 motorists places additional pressure on what is a fractured clinical service that has been starved of resources over the years. The proposed introduction of fitness to drive guidelines for Group 2 drivers next year will create an even bigger strain on the service, as it has been proven by a number of recent studies that the incidence of sleep apnea in professional drivers is as high as 28%. Taking this perspective alone, there is an undeniable case for a national strategy to deal with sleep apnea. After all, these guidelines have been introduced by a national regulatory body, and as a nation, these decisions must be supported. From a children's perspective, it is even more serious. To have a situation where we continue to ignore the plight of up to 3% of our children is unacceptable to ISAT. And I suggest to the people of Ireland there is an absolute no excuse for it. With the use of modern technology and committed people, the cost factor of a national strategy can be controlled. Thank you.
Thank you very much indeed. And could I just ask one question in the context of Beaumont Hospital, in the context of St Vincent's? The HSE have not responded to any correspondence.
I got no response from them.
And when did you last?
It's about 3 weeks ago, 4 weeks ago, yeah. I have had a response on Beaumont, all right.
You have on Beaumont?
Yeah, but it's kind of kicking for touch.
Okay. If the meeting is agreeable, I would propose that we would write to the HSE to know why they haven't responded back. Is that agreed? Yes. Okay, good morning. Thank you. Okay, thank you. And finally, but not least, I want to welcome and thank Professor Tim MacDonald, who is the National Clinical Lead for COPD, which is the Clinical Strategy and Programme Directorate, and also Mr. Micheál McGlynn, the chair of Support Ireland Group. So, President McDonald, the floor is yours.
Thank you very much, Chairman. I'd like to echo my colleagues' thanks to the senators and TDs for having us here today, and particularly to Senator John Crown for inviting us or organising the invitation. I suppose to start off with, I have a problem in that most people don't know what COPD is. Chronic obstructive pulmonary disease is a disease associated with narrowing of the airways, and this leads to the patient having two problems primarily. One, a difficulty with breathing, and secondly, a propensity to getting infections or exacerbations in the symptoms, which may lead to them seeking medical care either through the GP or attending hospital. And these are patients who are very numerous. They end up in the winter time, during the winter trolley crisis, producing a lot of patients that end up on trolleys, and if you like, contributing to a lot of the difficulties in the AED departments that we're well aware of. The confusion with the disease is, I guess, is it asthma? And the name is a difficulty for patients. A lot of patients who I deal with who've got COPD will tell me they've got asthma, they'll tell me they've got COAD, they'll tell me they've got smoker's asthma, all these sort of things. It's different from asthma. We've heard already from my colleague about asthma, and asthma tends to be associated with younger patients. It tends to be more reversible. COPD is a progressive disease. It tends to get worse as you go through life. So it is different, and it tends to affect a different spectrum of the population. The diagnosis is on the basis of a simple spirometry test. It looks at the airflow reduction, and basically that can be easily available, but unfortunately isn't. It's only available in perhaps 50% of GP surgeries, and that is certainly a problem. How common is it as a disease? It's certainly very common. We've heard a lot of figures here today, and a lot of the problem we have in the Irish healthcare system is actually providing accurate figures. But we reckon there are about 100,000 patients in the country diagnosed with COPD. There are perhaps 200,000 more who don't have the diagnosis made. It's a disease that's becoming more common with increasing age. We reckon that from Canadian figures that about 1 in 4 people who reach the age of 70 will need treatment for COPD. In terms of things that we can count, we know there are at least 12,000 admissions to our hospitals each year with COPD. There are probably more, but 12,000 directly related to COPD. We know that unfortunately 1,400 people die a year from COPD. To put that into perspective, we know that 1,400 people approximately die from lung cancer, which we now know is the biggest cancer killer in the country. So it's a huge cause of morbidity and mortality in patients. It's probably the most frequent cause of patients with chronic diseases being admitted to hospital, and the frequent cause of readmissions to hospital. Many of my patients with COPD have had multiple admissions to the hospital, and when you take it that the average length of stay for patients in hospital has been around 9 to 10 days, it does involve them being in hospital quite a considerable period of time. What causes it? It's predominantly caused by smoking, but not all cases are related to smoking. Other factors we've heard already that alpha-1 antitrypsin can contribute to it. People who have born premature can have a difficulty with it. It is associated with deprivation, and it does tend to perhaps reflect poor nutrition, things like that. But unfortunately, smoking is a big factor in it. A lot of the patients that have it are ex-smokers. So you can stop smoking and 10, 20 years later have done enough damage to your lungs that you present with COPD. So it's not fair to sort of say it's smokers and they should stop smoking, that's the end of the problem. These are people who've chosen to give up smoking, a lot of them, and are still afflicted with the disease sometime later. I guess, as I started off in the presentation, the issue is why is there so little public recognition for it? Well, the name is a problem. We've heard already about bronchitis and emphysema. COPD is pathologically bronchitis and emphysema, so it's a kind of a catch-all phrase for chronic bronchitis and emphysema. It's difficult for patients to remember COPD or chronic obstructive pulmonary disease. The disease takes decades to develop, and patients sometimes attribute the symptoms to basically getting older. I'm short of breath because I'm getting older, whereas in fact you're short of breath because your lungs have got damaged. It's more common in the poorer social groups, and I don't need to tell you that the poorer social groups tend to get poorer health care and poorer solutions to their problems. The chronicity of the disease is associated with some degree of guilt. Perhaps, the issue of smoking tends to make people less likely to demand resources for it, and people who've got used to the disease developing slowly just don't go looking for resources for it. And I have to say that amongst our colleagues, and indeed myself, I didn't do respiratory medicine to look after COPD patients. I was more interested in more exciting ends of respiratory medicine, but I ended up doing COPD. And basically, there's this nihilism that has been a part of the problem up until very recently. Doctors, nurses, weren't really interested in looking after COPD, and this reflected the public mood. I think that's changing for the good, and initiatives like the Lung Health Alliance and the Irish Thoracic Society are certainly pushing the agenda on this. But there has been, both in this country and other countries, a lack of awareness and a lack of interest in dealing with this problem. And to date, we've heard about various patient advocacy groups here today. There isn't, as of yet, a properly formulated group to support COPD, which is a huge number of patients. Mr. McGloin, who's travelled down here this morning from Sligo, is the chairman-elect of COPD Support Ireland, which is in the process of being formed at the moment. But that is a significant neglect for this very common, very troublesome disease. I'm here, one of my roles is that I happen to be the clinical lead for COPD in the HSE Clinical Strategies and Programme Directorate, and this has been established for a number of years, originally under Dr. Barry White, and more recently it's Dr. Anya Carroll has taken over the directorship of it. And with regard to the COPD programme, the idea was to reduce morbidity and mortality from the COPD through a number of initiatives. And time doesn't allow me to go through them at the moment, but there's been three that I think perhaps are worthwhile bringing to the attention of members. One is the COPD outreach service. This allows patients who ordinarily would have been admitted to hospital with COPD exacerbations be dealt with at home, or maybe discharged home somewhat earlier than they normally would have been. This has been pioneered in Ireland by one of Professor McElvaney's colleagues in Beaumont Hospital, Professor Richard Costello. But basically, the COPD programme, attempted to roll out this programme in 12 other sites around the country. We've had great success where it's got going. We've had to start in a number of places with limited staff because of the recruitment pause, and really we've been very much shackled by that. But in the submission I mentioned the 12 hospitals that we have got going on that. The second thing is that primary care is an area where a lot of these patients could be dealt with. We've been looking at strategies to try and get spirometry out to primary care so the diagnosis can be made in primary care and these patients can be looked after in primary care. And the third thing is pulmonary rehabilitation, which is an integrated program for looking after patients with COPD. It primarily revolves around exercise, and this is hugely beneficial. It's one of the most beneficial things I do for my patients, and this is something we've been trying to nationalise and spread around the country. Cost effectiveness is important for this programme, and basically I think this, obviously with the events of yesterday bringing money to the fore again, we need to show that we're producing benefits for the taxpayer, and already the programme's demonstrated a reduction in the average length of stay for patients looked after with this disease in Irish hospitals. We've reduced the amount of bed day units required for patients with this disease in the hospital by a factor of 10,000 from 2008 to 2011. So I think we are demonstrating some return on investment to the taxpayer. So thank you very much for your attention.
Thank you very much indeed. And I want to, at this stage, just give apologies from Deputy Dennis Naughton, Deputy Caoimhín Ó Cuaillán, who has been replaced for today's meeting by Deputy Michael Kilreevy. Deputy Ó Cuaillán sends apologies. He's gone on a north-south meeting to Stormont, and also Senators Colin Burke and Senators Gillian Van Turnout. There are apologies for this morning. Okay, I'll call on Deputy Kilreevy.
Thank you, Chairman. And could I, first of all, thank you all very much for coming in today, and repeat the apologies for Deputy Caoimhín Ó Cuaillán, who normally sits on the committee here and who has a tremendous interest in the topic. He is in Stormont today looking at the health services from a north-south perspective, and he did ask me to sit in for him. I'm taken aback at some of the presentations here today, because, quite frankly, I wasn't aware of the level of lung disease and its prevalence in Ireland. Caoimhín probably would have been, because he would have been involved in looking at the studies. But I have a lot of questions. I commend the work that you're doing in highlighting this and in making the public aware of it, and in highlighting this and making government aware of the problems and the issues that are out there. My first question is, do we have any longitudinal studies to help us to understand why Ireland has the fourth highest rate of asthma in Ireland? Because that's a staggering statistic. Do we know whether the prevalence is increasing or decreasing over the last 10, 20, 30 years? Do we understand why 20%, 1 in 5 of our children suffer? Do we understand, or have we looked at why poor people or people who are educationally disadvantaged or who have poorer educational levels have 4 times higher level of the disease? I don't understand how the rate of prevalence moves from 20% of children to 10% of the general population, if I understand correctly what has been presented to me. So that's in the area of understanding what's been presented in front of us. I ask whether people who suffer from chronic lung disease have automatic entitlement to GP, pharmacy and hospital services, medical cards. I wonder, is testing for chronic lung disease a part of the routine child health assessment programme that's done between a child is born and the age of 4? Or is there a test that can be applied to infants and younger children? Would it help if this were to be a routine part of the infant and child welfare programme? And do we have any information in relation to the impact, and I'm speaking both in terms of health, well-being and health economics, of early diagnosis and treatment of lung disease? And my final point for the moment is, there was little enough said about health prevention and promotion. Is this something that's hereditary? Are we giving up on it? Is it something we can do nothing about? Perhaps I've misheard or misread, but there wasn't a lot there in terms of prevention or promotion, apart from cigarettes. That's all for the moment, Chair.
Deputy, and Senator John Crown.
I'd like to thank my colleagues and sundry other allies for coming in today, and it's great to have the opportunity to hear your presentations. A few questions. First for Dr. Ed McCone. Ed, I mean, it is recognised that there are disparities in smoking across the socio-educational spectrum, but in addition to that, do you think there are other factors which determine the disparity in the incidence of lung disease across social groups? The next question I have for you is, how would we stack up in international comparisons in terms of the number of respiratory consultants per head of population? I would have a guess that we're probably somewhat worse in the UK and disastrously worse than any place else in the world. Britain and Ireland in general having disastrously low levels of specialists in most specialties. For my colleagues from the Asthma Society, it's frequently suggested that asthma is a disease where the advances in knowledge and advances in treatment have not necessarily percolated all the way down to the front lines of treatment, and that substantial further improvements could be made if doctors were to follow the best existing practices and the best medications. I just wonder what your take is on that in Ireland. Are we doing okay on that? For my colleagues from the Cystic Fibrosis Society, very quick question, one that was very topical here in this committee some weeks ago. Do you believe that an adequate number of beds have been built in the cystic fibrosis unit in St. Vincent's to comply with international guidelines for beds per sufferer in the population? And I'm very conscious collectively with all of you that you're right. You do harbour under somewhat of an extra burden because there is a perception that smokers are the people who get lung disease and it's their fault, and why should we spend any money if they just stop smoking? And of course it's a far more subtle and complex problem than that. But notwithstanding the fact that a huge part of lung disease is not related to smoking, if we were to have a complete disappearance of smoking as a habit, what would your estimate be on the percentage impact it would have on the demand for respiratory services across the country? And with respect to that, I'm asking you all to consider, when you go home, opening up your computers and looking at a website, SOS 2030, which is one that we have set up recently with the very ambitious plan of getting governments, the EU, the Commission, etc., to buy into the idea that we will pick a date in the future and say after that date it will not be legal to do for-profit commerce in tobacco. Thank you.
Thank you. And could I just again thank Senator Crown, not just for this meeting today, but also for being here despite having no sleep, so we appreciate that. Deputy Doherty, Regina Doherty.
Thank you. Thanks very much for coming in. And again, can I just concur with my colleague, because I had a view in my head this morning of what lung disease was, and it certainly isn't obviously anything like it's been presented to me, so thank you. I have a couple of quick questions that I can just dot around, please, if you don't mind. Ms Cosgrove, can I ask you two questions? Number one, you talked about the inequality of treatment on a national basis. What is causing that and what needs to be done to rectify it? Also, you said that there's certain parts of Ireland that don't have access to the drugs that other parts of Ireland do that are obviously of great benefit. Can you tell me why? Can I ask Mr Watt, please? You talked about the 13 adult beds that have been that are desperately needed in Beaumont. Where does that sit at the moment? Has an application been made for funding by your organisation to the hospital management? Has the application by the hospital management been made to the RDO? Has it even been applied for in the service plan? Was it ever in a previous service plan and just didn't get delivered? Where is that, please, if you don't mind? The Alpha One Foundation. Can I tell you, I'm not going to admit my age, but I'm not young anymore. I've never even heard of the Love Your Lungs campaign. Like, what are we doing wrong? And I don't mean you, but what are we doing as a Department of Health wrong to not, for everybody in the country to know how to love your lungs? I mean, we all know various other campaigns, and this one obviously seems to have missed. And when you look at the figures that are obviously far more stark than I would have considered, it's something that we need to do. So can you give me information, and please give us your advice as to how we can help, or the department can help, to get that campaign more exposure, please. Mr Smith, two questions, please. Number one, you talked about St Joseph's in Raheny being closed since last December. Why? Was it subject to a HICWA inspection?
Oh, sorry, yeah. Okay.
Sorry, was it subject to a HICWA inspection? Was that why it was closed?
I have no idea. I just heard.
No, we didn't answer the question.
Okay, right.
Sorry.
Sorry. If you can tell me why. And also, you mentioned, and maybe I hope I picked this up right, apart from the statistics of what we have in male and female adults, that there's a growing number of children presenting. Why is that? Are we screening children more and that's why we're finding them? Or is there another reason as to why it's occurring in children that we didn't know beforehand? And can I actually ask you, it's probably a silly question because there mightn't be just one answer to it, what actually causes it? Is it different cause in adults than it is in children? Is it something that we bring upon ourselves? Is it something that we're born with? Can you tell me just briefly maybe, or point me in the direction of where I can find more information as to what causes it? I'm sorry, I didn't catch your name. Thank you. Can I ask you, you talked about the bad reputation that the patients have that suffer from COPD. We obviously need to change that. So what can we do to change that, particularly in the view that you said that even people who have reformed, I understand and appreciate obviously that the vast majority of people who get it are either smokers or former smokers, but are we still treating and castigating people who've been brave enough to give up, but just 20 or 15 or 30 years later still catch COPD with the same awful brush? And actually, I don't even think we should be treating people with the awful brush. You know, most people who smoke don't want to smoke and find themselves in the difficult situations of not being able to give up. So this kind of treatment, I think, is unfair. How do you think we could change that? Thank you.
And Deputy Catchenburn.
Thanks, Chair. Thank you very much. Well, thank you very much for all your presentations. I think it's a pity you all had to come in together because there's a lot of information there. And I'm just going to kind of look at two because some of the questions have been asked. I suppose for the first speaker about lower education levels, people living in lower social backgrounds, probably diet and everything else. Would you be able to kind of broaden that, just give us a little bit more information on that? I would be very interested in that. It astounds me that the Asthma Association, that one person dies a week from asthma attack. I didn't realise that. And I suppose as somebody who has dealt in the past with City Council, I'm still astonished at the stage that I deal with a lot of people who have housing difficulties, housing queries, and asthma is not registered as a medical condition with the local authority. If there's water running down your walls and the dampness is over your head, it's still not classed as being living in poor conditions. And I find it astonishing when I go to any of the housing sections in City Council where a medical officer can say that conditions people are living in particularly very bad conditions in a lot of the old flat complexes, don't add to the serious illness of asthma. So I just wanted to say that. I suppose for somebody who's had the trauma of losing a loved one and having to, well, they've had a donor card and having their organs donated, I think it's a terrible traumatic time for the family in general. And I think the only comfort people have at the end of it is after a couple of months, maybe even after a couple of years, is maybe the loss of that one that they loved has led to giving life to other people. And on that, I'm just really concerned about the whole thing about how people view being a donor, particularly how it's pictured. How do you advertise people wanting to be? I know you can tick a box on your driving licence now and you're regarded as being a donor, but I think you have to be a little bit more user friendly. I think you need to go into schools, you need to talk to young people, you need to go into colleges. Not everybody dies in road accidents. We just happen to have a family member that did. But I think there's a huge link with young people now. If they know if they're given proper information. And I suppose one of the things that struck us when we were left with that dilemma was, do you sign this piece of paper? Do you make that thing that maybe if you leave the people in the coma state that they are in, that they might come out the other end? Because we do hear of stories now and again. And I think that has to be a part of the education of asking people to be donors, how sensitive the tests are, and that when somebody says to you, there's nothing there, that you need to be able to take that in as an individual. And I think that goes for people wanting to be donors as well. So if you have any, I'm sorry for going on, Chair, but if you have any evidence of being able to portray people wanting to be donors, I think it's very important that that message goes out to young people, particularly, that, you know, and the families. And it needs to be in colleges and schools and in workplaces like here. Because I don't think a box on a counter in a shop asking you to take a card is enough for me. I think it needs to be something else more.
Thank you, Deputy. Deputy Sandra McLaren.
I'll
take all the speakers and then we'll come to the questions, just because, to be fair to members who are here.
I'd certainly like to thank you all for coming in here this morning. Like other speakers before me, I had a different perspective as to what lung disease was. I suppose in my naivety would have thought that most of it would be down to smoking. Most of the questions have been covered, but with regard to the COPD, the narrowing of the airways, that it's different to asthma. You know, you were talking about running an awareness campaign, but you did say that only 50% of GPs surgeries actually can diagnose this. So even if you do run the campaign, you know, and people go to their GP, which they generally go to the same GP, how do they get diagnosed? With regard to alpha-1 and the hereditary emphysema, you said that there are 1 in 25 carriers in Ireland. Is there a database of carriers, and how do people know they're carriers, and how do they go about early detection?
Thank you. And finally, Deputy Mayor O'Connor.
Thank you very much. Thanks for all your presentations, and whoever will answer the question. I just, you know, you've talked about Love Your Lung campaign, sleep apnea, all the various different diseases and illnesses you've brought up. And I just wonder, have you got evidence that what has worked in other countries? Like, you know, if you run a very good campaign and Deputy Doherty said she never heard of it, I didn't either. So there's something wrong, and, you know, it's probably our fault as much as yours. But what can be done, and what can we do in here to help you? And I also want to say thank you very much to Professor Crown for informing this Health Committee today about lung diseases. Thank you.
Thank you. Any other member? Okay. Who wants to kick off? Dr. McEwen?
Okay, I suppose I'll start with two issues that were raised. The first one was related to socioeconomic factors and the impact it has on lung disease, and I think that is certainly worth elaborating on. And then Professor Crown asked a question regarding staffing and manpower. as I mentioned, lung disease is much more common in people from lower socioeconomic backgrounds. And in the past, that has been largely attributed to people who are poorer from lower socioeconomic backgrounds tend to smoke more. I think we have a lot of information that shows that although smoking is an important contributor, it certainly is not the biggest one. And I suppose the most compelling data is firstly is that diseases that are not related to cigarette smoking, in particular asthma, including cystic fibrosis as well, are heavily influenced by socioeconomic factors. Survival around the world is much lower. In North America, if you don't have private insurance, inner city asthma is a massive problem, and it's not smoking related, it's due to asthma and due to other environmental factors there. So we know the socioeconomic factors independently affects conditions like asthma and COPD, or asthma and CF. For COPD, our own data, and this is Irish data that we collected on World Spirometry Day in June of this year, we did free lung function testing. We offered it around the country. We had 750 people who came and had lung function testing done. Half of those had never had a diagnosis of lung disease ever in their lives. And of those, 1 in 7 had airflow obstruction suggesting asthma or COPD, and 1 in 5 had abnormal lung function. So again, just highlighting the prevalence of this condition. But we also asked people questionnaires regarding smoking habits and also their educational background. And just to reinforce, the educational level is actually one of the best determinants of socioeconomic background. It's better than asking people about their income or their jobs. So educational level is very helpful in predicting that. And what we found was that lung function on average was lower in smokers, as you would expect, but there was an independent effect that socioeconomic factors had on lung function, and obviously there was a significant lower level of lung function in people with who had only educated to junior cert level. Now, it's clearly not simply an educational issue. There's a lot of factors that are tied in with this, including awareness, and that's been mentioned repeatedly today, that getting the message out there that these symptoms people have, actually, you should do something about them. Access to healthcare is another issue. I mean, we have a good public health service, but there are limitations, and people and access can be a little bit disparate. There are certainly environmental factors as well, and I suppose as was mentioned, you go to housing, exposures, the type of jobs people have as well, the jobs that involve exposure to dust, fumes. These are the things that all cause lung disease that are not related to smoking as well. And in addition, even conditions like healthy air, that you're living in a poorer environment, maybe in the centre of a city with a lot of traffic, you're exposed to more pollutants. So these are the sort of multitude of factors, and I will admit that we would like to do more work on that. I think that when you look at outcomes that for people from different socioeconomic classes, we spend a lot of money on drugs, that if you could find a way to bridge those outcomes, you could probably have a much bigger impact than a lot of the money that we spend on medications. And I think that's an important point. To then just move on maybe to the second question regarding manpower. There are 50 public consultants in respiratory medicine in the country. Looking across Europe, and there's actually a white paper coming out from the ERS later on this year. We try to get access to the hard data. We don't have it yet, but as Professor Crown mentioned, we fare very badly compared to other European countries in terms of delivery of respiratory health care. And that includes consultants, that includes respiratory nurses, that includes respiratory scientists, physios, and as well as primary care. To give it a number, currently there's about one consultant for about every 80,000 in Ireland, where in the UK it's about one for every 50,000, and they're actually looking to decrease that number. They're looking for more. And I think to equate to what number of consultants they would have in the UK, we'd be looking at an additional 30 consultants here. In terms of respiratory nursing staff, which are critical for doing the breathing tests that have been mentioned here to identify lung disease, we would also need to see a substantial increase in those in the hospitals. But this, I think, is being addressed by the asthma programme and by the Professor McDonald's COPD programme.
Okay. Sure.
Address your question on Alpha-1 and detection programs. So with regards to Alpha-1, we have a very good idea about how many people in Ireland have Alpha-1. We estimate that 170,000 people in Ireland have the MZ form, and over 3,000 have the ZZ form. Now, what does that mean? If you're a ZZ, if you smoke, you'll get severe emphysema in your 30s and 40s. Even if you don't smoke, you have a good chance of getting emphysema. The advantage of our targeted detection programs, our programs to detect this condition early, is that we know from our own data that if you're detected with this condition, we can get you to stop smoking, and we can institute a lifestyle change that will help prevent progression of disease. And so what we have done is we have set up a targeted detection program in Beaumont Hospital, which is funded by the HSE. Now the funding has been cut, but it's still functional. And what we can do is offer a free test to everyone in the country. So everyone in this country can get tested free gratis for alpha-1 antitrypsin deficiency. We have rolled this program out to over 26 hospitals throughout Ireland and to GP surgeries. So if you're a GP in West Cork, you can send a letter to us in Beaumont. We'll send you out a kit. You can take a blood sample from your patient, put it on a filter paper, dry it, and send it to us, and we make the diagnosis. And not only that, we'll then give you a place, a place in our outpatient setting in Beaumont Hospital, and we'll give you a full workup on your alpha-1 and a lifestyle improvement pro forma that will help you. And the data is, if we can detect this condition early, we can preserve lung function, we can prevent deterioration leading to lung transplant, etc., etc. And probably more importantly than that, it's a good example of a public system that works. Adults and children. And the reason that it's important for children, if you look at alpha-1 antitrypsin deficiency in children, 10% of severe alpha-1 presents in childhood with severe jaundice. Of those children, 1/3 will require liver transplant in the first year of life. So again, early diagnosis is extremely important.
Mr. Smith next, and then I'll go up to Sharon then after that. And then move over to Dr. Down, then back to CFP. Okay.
Sorry, on the St. Joseph's Raheny situation, it should be borne in mind that because of problems with getting beds in Beaumont, the sleep clinic was transferred over to St. Joseph's in Raheny, and it was funded entirely by an outside agency on a charity basis, where a 5-bed day ward was converted into 3 private rooms. The condition is that only public patients can be treated there or diagnosed there. There are no private patients allowed in. There was a control room put in as well too, and the individual wrote a cheque for 150,000 as a down payment on 3 years' salary for a respiratory scientist to man it, with the promise after 2 years to write a further cheque to meet any shortfall. This was done on a charity basis. The HSE had no input into it at all. Now, what has happened, I don't know, but the sleep clinic was closed down in mid-December. There have been no sleep tests carried out there. And nobody seems to know what's happening. I have written to the HSE.
Can you give us a copy by email after the meeting of that letter? If you
I can indeed, yeah.
Please. Thank you.
In the case of St. Joseph's, I have received a response which has passed it on to another area manager, and I assume something will be done. In the case of St. Vincent's, I've heard nothing. But the situation in St. Joseph's, it's a very effective sleep clinic. The throughput is very, very large, and it is really performing. And to take it off the grid effectively, whereas in the Dublin Northeast area, there's a small clinic in the Lourdes and Drogheda, there's a unit in Blanchardstown which can't get beds, and there's a very small unit in Cavan. That's it. Now we have a situation where all these additional things are coming on stream. Somebody has mentioned to have an awareness campaign. The problem with that is we clog up the waiting list because there's no service there if we have an awareness campaign. You know, it defeats the whole purpose. And this is where the national strategy is required. You asked also about children, and I'll just give you some of the reasons why children get it. Down syndrome is a prevalence of 1 in 1,000 children. And the prevalence of sleep-related breathing disorder, which is sleep apnea, is 70 to 100%. It's a high risk of pulmonary hypertension, especially in coincident heart disease. There's neuromuscular disease. The prevalence is 1 in 3,000. 42% have a prevalence for sleep-related breathing disorder. It's very difficult to detect clinically, reduced life expectancy, and reversible by treatment. There's craniofacial abnormalities. That's a prevalence of 1 in 7,000. Now, it depends on the severity, but it's pretty much 100% chance of them having sleep disordered breathing. There's a condition called achondroplasia, which I'm not probably pronouncing correctly. There's a prevalence of 1 in 25,000. There's a 48% prevalence of sleep apnea. Mucopolysaccharidosis is 1 in 40,000 prevalence, and it's a greater than 90% prevalence of sleep disordered breathing. And it's the Prader-Willi syndrome, 1 in 52,000, is a 25 to 75% prevalence of it. These are hard figures provided by Crumlin Hospital. Now, You asked about the causes of sleep apnea, and again, another thing about our children born. Half of 1% of children are born with sleep apnea. Now, how it develops is usually, it hasn't been clinically proven beyond any doubt, but there's been 1 or 2 small studies done that indicate that it's not genetic, but hereditary. And a lot comes down to the craniofacial build of somebody's face, particularly with a receding jawline. Years ago, I was always saying it was obesity. Lose weight and you'll be fine. But there are more and more thin people getting sleep apnea, and it's down to their craniofacial structure. There's also the fact that our tissue within our airway gets weaker as we get older, so it starts to collapse, and it just closes. And this is where we get when we get sleep apnea. Your airway just collapses.